All right. Hello, everyone. It is 12 o'clock here in Vancouver. Welcome to our May NCCEH Environmental Health webinar. My name is Tina Chen, and I'm a Knowledge Translation Scientist at the National Calibration Center for Environmental Health. Please make sure to turn your cameras off and put yourselves on mute throughout the webinar. And please type all communications into the chat box. You may type your questions into the chat box at any time during the webinar, and we'll get to them at the end after the presentation. Today, my colleague at the NCCEH, Dr. Angela Eichelbosch, will be talking about her work on indoor carbon dioxide sensors for COVID-19 risk mitigation. Dr. Eichelbosch is an environmental health scientist and knowledge translation specialist who works on a range of environmental health issues. In response to the COVID-19 pandemic, Dr. Eichelbosch and the NCCEH team have dedicated their efforts to gathering and synthesizing public health evidence to better understand the risks of disease transmission in indoor environments, including homes, workplaces, and public settings, as well as the tools and strategies to mitigate the risk. Over to you, Angela. Thank you.
Great. Thank you very much, Tina. Okay, yes, I am not on mute. So as Tina said, I'm going to be talking about CO2 sensors today. And I just want to let everybody know off the bat that this new CO2 work that we've started is very much in progress. And so if you say something particularly intelligent or useful in this, in the questions or in the chat, I am totally going to steal it. I'm just letting you know. Our documents are living documents, so your good input helps us improve them. Just FYI. So before I get started, oh boy, that doesn't want to advance. Why?
Might want to click on that. Yeah, there you go.
So are you able to see my video, Tina?
Yes.
Oh, okay. So before I get started, many of you will already know this, but the NCCEH webpage has a COVID-19 topic page. If you go to our homepage, ncceh.ca, it's right there on the homepage. You just click on the COVID-19 tab and it takes you to our environmental health resources for the COVID-19 pandemic page. And so this gets periodically updated with all the best resources that we can find. It hasn't been updated this month yet. That's my next thing to do. So if you check back in about a week, 10 days, it will have a bunch of new stuff on it. Okay, so today, we're going to be talking about CO2 sensors on a range of topics. First, we're going to just talk generally kind of about responding to the pandemic and where we're at. Then I'm going to be introducing this concept of CO2 sensing for the pandemic. We will be talking about some of the key concerns and challenges that were identified through my little working group of experts that help me on these documents that the NCCEH produces. We'll be talking about the difference between CO2 concentrations and COVID-19 risk. We'll be talking about kind of the more general challenges of using ventilation for risk mitigation. And then we'll sum up with some kind of key points on the role of CO2 monitoring as a public health tool. So before we get started, I'd just like to say, welcome to your 441st day of the pandemic. I know that the work is hard, and in some cases it's getting harder for some of you out there. I was really upset to see the coverage in the media about PHIs being harassed on the job or having to even take police officers to the job site. Like, that's just absolutely insane. So in case anybody hasn't said it in a while, just wanted to say you're doing great and thank you very much. You know, we're getting there slowly. So while I have you there, I also want to put out a couple of questions to you. Over the next few months, all of us will hopefully be shifting more into a recovery phase. I know we're not all there right yet, but you know, it's coming. So the NCCEH is looking for input. We want to know what you think will be the greatest environmental health challenges in the next 6 months. So if you have input on that, please put it in the chat. Or you can always, of course, email us at contact@ncceh.ca, or my email address will be at the end of the presentation. And while you're at it, we're also trying to be thinking about the longer term now. So what kind of lessons or behavioral changes can we leverage from this pandemic experience to improve public health generally? So These are the types of questions that NCCEH is pondering right now. Okay, so CO2 sensors. Today, we're going to be talking about CO2 sensors as a COVID-19 risk reduction tool. Over the last 15 months, I've been really focused on these issues of aerosol transmission and mitigating COVID risk indoors and also ventilation. I am not an HVAC specialist, but I have been looking very deeply at these materials with a public health lens. And one of the things that I have struggled with a lot over the last 15 months is, even though we know that poor ventilation is a COVID risk factor for sure, and we do know that many indoor spaces are probably substantially underventilated, it's actually very hard for operators or businesses or members of the public to know when their space is adequately ventilated. We've got this phrase in a lot of our guidance documents. Make sure your ventilation system is running according to its design specifications, stuff like that. But in fact, it can be really hard for people to know that their space is actually adequately ventilated. So unless they hire, of course, an HVAC professional, which they maybe will not or cannot do for some reason. So this idea of using CO2 monitoring to assess and address COVID risk is very attractive for that reason. It's also been used for years. It's not in any way a new concept. So some examples of using CO2 monitors as an indoor air quality tool include things like in demand controlled ventilation, which I'll talk about a little bit later. And there's also been a ton of work done on CO2 levels or reducing CO2 levels in schools. And this is really related to a body of research that says that when you have CO2 and other indoor air pollutants, so indoor air pollutants of which CO2 is an indicator, accumulating in indoor space, it can affect decision-making, cognitive performance, fatigue, headaches, all these other things. So it's kind of like a general, having a healthy space, but not related to infectious disease. So CO2 monitors are also pretty ubiquitous. They are cheap, they're getting cheaper. They're also widely available in the marketplace. And theoretically, anybody could buy one of these and stick them up on the wall and start monitoring CO2. So the focus of this presentation is, whether or not that's a good idea. And if it is useful, how can we do it well? So what's theory? So this is kind of the basic gist, and that is that humans exhale CO2 when they breathe, obviously, and they exhale a lot. So our exhaled breath is about 40,000 ppm CO2. And when people start to gather together in an enclosed space, each additional person is going to bump up the CO2 level relative to the ambient outdoor level, which shouldn't be higher than about 450 ppm in this new climate present that we're in. I'm not going to call it climate normal because, of course, it's always changing. Depending on the number of occupants and their activity level, the amount of CO2 in the space should scale upward pretty reliably with the number of occupants. And if there's no ventilation, if everything is closed up, or if ventilation is there, but it's just really insufficient, that CO2 is going to accumulate. So the upward trend is the red flag. So this is extremely useful information, and it can be used in a variety of ways. So in the research world, CO2 monitors and CO2 levels are often used to estimate ventilation in a space, just to understand, how much fresh air is actually coming in here. But CO2 monitors can also be used in very specific applications like demand controlled ventilation, which uses indoor CO2 levels to automatically increase or decrease fresh outdoor airflow or fresh outdoor air intake, depending on the occupancy. So when the building is crowded, like here on the left, the building is full, CO2 levels are high, this control panel tells the outdoor air damper to open right up, and you start getting a lot of fresh air flowing in to meet that ventilation demand. However, as an occupancy decreases, then there's a corresponding downward trend in the CO2 level. The control panel registers that and starts to close the damper or decrease that outdoor air fraction. So this is great because it obviously saves a lot of money on heating and cooling that air being taken in, and it helps keep the building at a kind of even keel, comfortable for all the occupants involved. During the pandemic, incidentally, facilities were advised to turn off or to disable their demand control ventilation systems or set the set point to 400 ppm, because we wanted to be sure that fresh air intakes weren't going to be shut off if CO2 was low. And so you could think about a situation, for example, like a long-term care home where people are sedentary, they're not producing that much CO2, but there's still a lot of people in there, and you would not want the fresh air intake to be turned off. That could be very dangerous in a pandemic situation. So, okay, so the question is this: during the pandemic, can we use CO2 monitoring to improve ventilation or to stimulate changes in ventilation behavior and decrease the risk of COVID-19 transmission because the space is better ventilated? So who is currently recommending this? Surprisingly, quite a few large organizations are now starting to mention CO2 monitoring. So REVA, which is the European ASHRAE, I forget their full name, they are currently recommending CO2 traffic lights in schools. So a CO2 traffic light is just what you see here. You've got some warning light indicators, you've got a couple of thresholds, a lower threshold and an upper threshold, and as each threshold is tripped, a light flashes, and this flashing is meant to get you to take action, like open a window, air the classroom out, everybody goes outside for a recess, something like that. So that's in the REVA schools document. There's also in Germany has taken this to the next level. I have here it recommends CO2, but I think they might actually be mandated in some cases. So, you know, they have actually very good specific guidance on the use of CO2 traffic lights. Let's see, the CDC has a section now in their webpage on ventilation about using CO2 monitors, and most of it is actually caveats about how it can go wrong, but they do acknowledge, like, if you're going to use this could be useful for kind of raising indoor air quality awareness. And related to this, the Minnesota Department of Health, they're using CO2 monitoring in schools now, and I believe the schools have to keep it below 800 ppm. So we'll be talking more about action points later. And the last one that I wanted to bring up was the Washington Department of Health, which is probably the best use of the CO2 monitor I've seen so far, which is it's basically to ensure that an open air eating space really is open to the air. So as many of us here know, it can be very difficult to define a patio because you can have pony walls, you can have a roof, you have awnings, you have plants, you have shades, you have all sorts of things that could block airflow, and it may not be totally clear if that space really is open to the air. So what Washington Department of Health did was they said, Washington State, they said, okay, you've got your CO2 sensor, you've got two people seated at this table. If their local CO2 level is more than 450 ppm over 15 minutes, they have to be moved. It's not open to the air. So that is a really kind of a simple and useful approach, because the action point is outdoor air, and that's very easy. You know what outdoor air is supposed to be. There's also a scientific advisory group in the UK that wrote a pretty good white paper about using CO2 monitors. And they noted that it was very useful to prioritize poorly ventilated spaces. And we are seeing some school districts actually doing that now in Canada. So there's definitely interest in using CO2 sensing for COVID risk mitigation, but there's not a lot of guidance on how to do it well. There's a lot of like warning, red flag type of material, but not a lot of like how to actually roll this out. And really, this is about the fact that it's kind of difficult to take this thing, which is it's an IAQ tool, an indoor air quality tool, and turn it into a public health tool. So as an IAQ tool, these CO2 monitors, they're usually designed, installed, used, and decisions are made by professionals, and they're usually calibrated. They're usually part of set it and forget it systems where occupants are not required to interact with them at all, which is great. And the objective there, as I said before, is really about making those HVAC systems more cost efficient, more energy efficient, and also making the people more comfortable and giving them healthy air. But healthy is really defined based on this research around kind of performance and decision making and fatigue, not around infection control, which is what we care about now. So on the other hand, if this were to be rolled out as a public health tool, then we have to really ask the question, can these devices be used and interpreted by non-experts, occupants? And again, that objective is now to prevent transmission of respiratory disease by increasing ventilation in badly ventilated spaces. So can that be done? And, do we have better tools they're actually better than CO2 sensors? And, we've been doing this since last year now, so it may be that CO2 sensors actually are not necessary. So what are the key concerns? So whenever NCCEH does one of these field inquiries, which is what this document, the CO2 document is, we kind of start by taking the question and putting it out to a group of experts. It's our expert consultation. And when we do that, so when I started this, I actually put out this question to a bunch of IAQ experts in my network. And just to kind of get an idea of what could go wrong or what the key concerns were. So these are only some of the key concerns. The rest are in the paper. So the 4 I'll be looking at today are really centered around that monitor quality issue, which is a really big one. Choosing a threshold can be very problematic. This problem, it's a really serious problem because it affects how people make decisions, is when people start equating CO2 levels with COVID-19 risk. That's a big problem. And then finally, there's just some general questions and perhaps troubleshooting around how occupants are going to react to having a monitor and having to interact with a monitor. So it's not going to surprise anybody here that a lot of the low-cost CO2 sensors that are out there on the market can vary enormously in terms of accuracy and quality. And obviously, it's not possible for us to vet all of them or any of them. I'll talk a little bit more about that later. The data that I'm showing you here is from an assessment of 90 CO2 sensors that were installed in public buildings in California. And they were actually being used for demand control ventilation. So these are not cheap sensors. They were actually designed for use with DCV systems, and they were installed by professionals. And they were also theoretically, they were also calibrated at installation, and then also they were supposed to be calibrated once per year. So you can see from these 2 graphs, which are from this paper down here, that at this upper measurement point around 1,000 ppm, only about 30 of the sensors were dead on. The rest of them kind of varied in these 2 tails here in terms of being above or below the actual true value that they were being measured at. And when they went down to a lower measurement point around 760 ppm, this kind of flattened out a bit more. So more of the sensors became more inaccurate. And so that's a really big concern. In addition to this kind of difference around the 2 set points, the monitors also really varied in terms of what manufacturer made them, the sensor type. So there was like little differences in design, and whether or not the sensor had a self-calibration feature. So overall, about a quarter of the sensors did not meet California's required 75 ppm error, allowable error at this upper level. And I think it was about 40% didn't meet requirements at this lower measurement level. So that's a big problem. Also, the age of the sensors didn't seem to make a difference. There were much older sensors that were working fine and newer sensors that were way off. And they also found that a lot of the sensors, although they were being calibrated at installation, it was maybe a little bit hit and miss after that. So there was definitely some maintenance issues. So in this particular study, these authors actually suggested that maybe having something like an electronic eye, which is like a sensor to a people counter to count the people going in the room, that might actually be a better measure of occupancy than trying to use CO2, because these sensors were a little wonky. So that's just one example, right? And as I say, for the vast majority of the new, small, low-cost sensors coming on the market, I don't know how accurate they are. So how to deal with monitor inaccuracy. So one thing that can be done, obviously, is you can start developing criteria for choosing a monitor. And I kind of have some suggestions in the paper about what kind of functions to look for, but that could be expanded to include things that would help assess how accurate the monitor is going to be. REVA in Europe, in their guidance document, they actually highlighted this particular model. I don't think they named the company, but they do show it. And so for me, that's kind of like a tacit endorsement of the product. And, one assumes that they had some sort of idea how well this monitor works. I don't know that, but, once you start showing a product in your guidance document, then people are going to start assuming that this is the one to go for. Great news for that company. There was several that they showcased. Overall, though, you just kind of need to have a plan for maintenance and recalibration of these things if they're going to be in place over the long term, if they're a long-term solution, which they may not be, and we'll get to that in a second. So the next issue that came up in our group was really about choosing an action limit. And this is really tricky. The CO2 thresholds that exist now and ventilation rates that are, promulgated by ASHRAE and REVA and the rest of the professional organizations are really based on comfort, okay? They're not based on infection control. I'm not going to say they're not health-based completely, because ASHRAE does have a definition of healthy indoor air that is, one that's free of contaminants or pollutants, or so it's not going to make somebody sick. But the CO2 thresholds that are promulgated are really not about infection control or those the associated ventilation rates. Very recently, just last fall, Health Canada actually did derive a new CO2 guideline for indoor spaces, like I think residential, but it could also be other indoor spaces. And this was based on that body of research related to fatigue and performance and decision-making and cognitive impairment and respiratory symptoms, of the whole gamut. And if you're interested in that, you should look at this is the reference for that document. And they go through all the different research, and they come up and they say, okay, well, 1,000 ppm is probably a good limit for CO2 based on this research that we see. And it may not necessarily be that CO2 is what's causing those effects, but that it could be, it could just be an indicator for any of the other unknown indoor air pollutants that, could actually be having this effect. So, and that 1,000 ppm conveniently lines up with the typical value used in just kind of IAQ generally, which is 1,000 ppm. However, we have to then ask what CO2 concentration, or more accurately, the ventilation rate associated with that CO2 concentration, is going to protect against disease transmission. So in order to answer that question, we need to talk a little bit about how effective ventilation is generally against disease transmission. There's been quite a lot of work on ventilation rates and ventilation types and the associated kind of changes in terms of disease transmission. So we do know that a lack of ventilation, so I mean no ventilation, is associated with respiratory disease transmission. So that is, very obviously any kind of virus like COVID or influenza or common cold is going to opportunistically take advantage of a zero ventilation system and spread. So probably the best example of that is that restaurant outbreak in China last year, where they actually spent quite a bit of time characterizing the space and figuring out, where the ventilation assets are and what is the airflow like. And basically they determined that the fresh air ventilation rate for that particular outbreak was about 1 liter per second per person, which is way too low. It was basically just the fresh air that could get in through the door every time it was open. So really bad situation. Unsurprising that the virus was able to spread within a pocket of kind of non-mixing air that was circulating, but it was not mixing with the rest of the room air, kind of a pocket in the back of the room. We do know also that adding in mechanical or natural ventilation, good, not just infiltration, but I mean like actual designed natural ventilation to a totally unventilated space, is also going to reduce transmission. So just last year, there was a pretty good paper by this Zhu et al. that looked at actually lab confirmed acute respiratory infections in college dorms. And they looked at I think it was a mechanically ventilated versus an infiltration only building. And of course they used CO2 sensors to figure out what the ventilation rates were. And the difference was between, about 6 liters per second per person versus about 2. And there was a big difference in the number of respiratory infections that came about. So, however, this is where it gets sticky, as it usually does. We know that over-ventilating can also cause an increase in the risk of transmission. And the reason why, there's a whole bunch of reasons. One is airflow dynamics. So just having like a turbulent jet of air shooting across the room, it's pushing, it could push somebody's droplets much farther than you expect, or push any of their particles farther than one would expect. There's also effects related to the distribution of air in the room or the mixing of air in the room, especially if you somehow create kind of a flow path from sick person A to healthy person B. There's differences depending on what type of ventilation system you have. So there's, common types are displacement ventilation versus mixing ventilation. And then now I'm seeing more stuff about personalized ventilation, which is basically just when you have an exhaust above your workstation. So it's drawing your particles up and out continuously. And then also there's effects depending on your relative position in the room to a sick person, and also your posture. So if a person is seated or standing or lying down, the sick person is seating or standing or laying down. And so depending on your position, displacement ventilation may have a different effect on your relative risk of infection than mixing, but it may not be what you expect. So if you want a really great discussion of these particular problems, this paper here, Shah Jahan, it was from 2019, and they look at all these kind of different environmental parameters, including ventilation rates and types of ventilation systems on infection control in hospitals. So really good read. But the point of bringing all this up is that it can be really difficult to specify a minimum ventilation rate to prevent disease transmission, because it's very much about optimizing for the space. So if you do have to choose an action limit though, what are you going to choose? So the typical indoor guideline is 1,000 ppm, as I said, which is equivalent to, depending on various factors, about 7 liters per second per person. And you can see in this table here to the right, that has been scaled down to about 800 ppm by some of these different groups. So, Germany stuck with 1,000 ppm, but the Minnesota Department of Health, they went down to 800. RAVA went down to 800. This UK Scientific Advisory Group, they said, well, if you're going to be doing aerosol generating activities, so that could be medical procedures, that could be singing, that could be high intensity exercise, then you should be aiming for, not exceeding 800 ppm CO2. CDC likewise went to 800. So that corresponds to a ventilation rate of about 9.5 liters per second per person. Click, there we go. But again, as mentioned here in this table, you also have to consider activities that are being done in the space. So maybe if you've got really high intensity exercise, you should be saying, well, actually, you need to open up those windows and try to get CO2 as close to ambient as possible. Or, there might have to be some additional considerations for activities. You also have to consider what is practicable, what can be actually put into practice. So there's going to be some situations in which it's not going to be possible to get the CO2 level down even below 800, and that may or may not reflect any kind of change in COVID risk. So for example, if you've got an office and there's a portable air cleaner working, well, that is reducing your COVID risk. It's theoretically removing particles if it has been installed properly, but it's not taking out CO2. So your CO2 levels could be going up, but your COVID risk actually isn't. So this is one of the problems with using CO2 sensors. So that's all well and good, okay? But here's another really important thing to keep in mind, and that is that there's only so much that ventilation can actually do for COVID risk mitigation. So we're talking about mitigating this one part of a multifactorial transmission thing that's happening. And so ventilation only addresses that one part of it. And so here's the reason why. We know that if we have a room like this one, we've got a sick person in it, and we've got all these ventilation assets. We've got an air cleaner, we've got a UV lamp, we've got an air cleaning asset, we've got some natural ventilation. Here's another air cleaning asset down here. And so basically, if you've got all these things working, they're going to help reduce the concentration of infectious respiratory particles in that space. And if you're this guy way over here, it's probably going to reduce your exposure. And so it should reduce your risk depending on the disease, right? Because some diseases may actually be more infectious than others. So he's going to be right. However, if you're this guy right here and you're standing right in the cloud of this person's infectious concentrated respiratory particles, aka the hot zone, all of these other kind of ventilation and air cleaning assets are not really going to have that much of a, not going to provide that much of a benefit to you because you're just too close for it to be useful. So the message here really is that ventilation is a support to kind of this risk mitigation endeavor we're all in. It's not a solution. And that's kind of one of the problems with CO2 sensors, is that they can be kind of viewed as a solution, and that's not a good idea, because this type of short range transmission here is much more important to the pandemic than this kind of longer opportunistic long range transmission. So, you know, if this is the part we really need to focus on reducing, then, you know, it would be detrimental to distract from what is going on here, essentially. So you really can't ignore, in other words, those public health measures like reducing crowding, but also, you know, hand hygiene and wearing a mask and all these other things. So while we're on this, related to this, one concern that was raised, and has been raised many times, is that if we start using CO2 sensors to assess ventilation adequacy, people are going to start equating CO2 level with COVID-19 risk. And that is not a good thing, because it could lead to some really bad decision making, as I just mentioned, with the fact that, you know, the short range transmission is really important. So here's why. Although these CO2 levels in the room scale pretty reliably with the number of people there and the need to ventilate, CO2 levels and COVID risk are affected by different factors independently. So there's too many things going on that may affect CO2, but not COVID, or COVID, but not CO2. So depending, for example, where you place the CO2 monitor, if you place it here, if you place it very incorrectly over here by an open window, that would be never the place you should install a CO2 monitor. But these two CO2 monitors will tell very different risk stories for the people that are in this room. And, you know, it's really just kind of not relevant. This guy is at risk, definitely, for sure. Whereas this monitor may show a very low CO2 level. And in addition, you've got a portable air cleaner in here. So as I mentioned, this will be reducing the COVID risk by taking out the viral particles, but it won't be affecting CO2. So there's another disconnect between CO2 levels and COVID risk. Then who knows, somebody might bring a dog in. So the dog is increasing CO2, but not affecting COVID risk. If you work in a kitchen, there might be open flames, for example, or hopefully the dog isn't on fire. Did not think about that. So a flame, for example, is going to increase CO2, but not affect the COVID risk. So there's really just too many things that can be happening in here, so that being exposed to a high CO2 level does not mean you're going to get COVID necessarily, but also having a really low CO2 level doesn't mean you can't get COVID. They're just not connected. And that's really one of the key problems with using CO2 monitors, that it might be seen in that way. So this is a really good point to plug a new document that Public Health Ontario just put out. It's part of their What We Know So Far series, and it focuses on COVID-19 transmission through large respiratory droplets and aerosols. And they really try to break down this body of evidence related to all the, all right. So they cover all the modeling studies, which is basically kind of the airflow dynamics and how particles spread in a room. They looked at a bunch of field simulation and chamber studies, which is where you actually set up mannequins in a space and you look at, like, you know, what levels are exposed to. And then they looked at all the epidemiological evidence around COVID-19 transmission dynamics. So what they do is they kind of break this down. They talk about the short range transmission risk, which is really what we have been battling against for the last 15 months. And then they try to set that apart from the opportunistic longer range transmission risk, which, yeah, is a problem in very poorly ventilated spaces, but it's something that we know how to mitigate. So I highly recommend taking a look at this document. It's really useful. So this is all to say that COVID-19 transmission is extremely multifactorial. It's a very, very, very big mistake to try to simplify it and talk about one particular route of transmission over others. So the multifactorialness here, we've got community transmission is a big part. We've got, oh, there we go. We've got individual factors related to the host, related to the person who is vulnerable. We've got proximity and duration, we know, of an interaction with a sick person are absolutely key. We know that unventilated spaces are a potential problem. There's a bunch of environmental factors that may come into play, like temperature and humidity, and the presence of UV may be really important. Particle generating activities we know are very important. That's your singing and your dancing and your jumping around, that sort of thing. Fomites have been kind of downgraded in a way, but they're still in the mix for sure. We would never tell people to stop washing their hands, for example. So if you're interested in fomites, Tina, who's moderating here, wrote a really good document on the evidence around fomite transmission that came out just last month, I think. So that's also on our website. And so this is all to say that, public health uses these layered measures that address multiple factors and multiple routes of transmission. So really kind of focusing in on one particular route of transmission, and through the use of CO2 monitors, kind of like amplifying that in a way is actually not helpful and could lead to some very poor decision making. So the last thing I want to talk about is anticipating occupant behavior. So this is definitely the thing that if anyone were to try to roll out some CO2 monitoring, either during this pandemic or the next one, then, this is something that would require a lot of troubleshooting and a lot of risk communication. So one of the big issues that I think I've kind of already beat on quite sufficiently here is that people will maybe focus on the monitor and focus on that number and not necessarily focus on other health protective actions. So there is a risk of over focusing on the technological asset, the technological solution, rather than having that awareness and thinking about, what are all the measures that I need to be using to keep myself safe. There is a potential that people will panic and misinterpret when comparing data. So if we go back and we look at that data from those monitors, that some of them were 300 ppm off. So you can imagine you might have a situation in an office building where one room is sitting at about 800 ppm and everybody's happy, but down the hall there's a very similar room and that room's at 1200 ppm. And why is that? Is it because there's a problem with the room? Is it because there's a problem with the monitor? So that needs to be troubleshot. And then, the fact that you've now exposed people to CO2 above this magical number that they've been told is important. What does that mean for their health? So there's a lot of room for, it really requires a lot of very careful risk communication and, putting the CO2 monitor in context with other health protective measures. So this point is actually probably my biggest concern. And that is that if you set an action limit and you tell people, okay, you got to stay under 1000 ppm, people will only act when they hit the action limit, not before. And so what we actually want people to be doing is we want them to be regulating as close to ambient as possible, trying to keep the CO2 levels as close as possible by having their windows open as much as possible, where that's possible, depending on the HVAC setup and other factors. So, but this idea that if you set a relatively high action limit, like 1000 ppm, people being people will try to do the minimum and they will try to stay just under 1000 ppm, which is not the point. So I talk a little bit more about this in the paper, but basically, rather than setting an action limit, what you could do is you could have a monitor that shows a trend, and you could tell people, if you see this going up, or maybe there's an arrow indicator going up, if CO2 is going up, then you need to open a window, or you need to regulate around that, not necessarily around an action limit. So then the last issue is just that people may not stick with it. So people may focus on the monitor for a week or two, but then over time, perhaps these will not lead to real change in behavior. So as I mentioned earlier, there has actually been a lot of studies on schools and CO2 levels in school, and this idea that we need to regulate CO2 levels in school because it affects learning and performance and like cognition. And yeah, so there actually have been quite a few field studies that have tried to look at CO2 and tried to find ways to reduce it. So the one that I'm showing you here is actually from 2008. It looked at the effect of 3 different interventions on CO2 levels in 81 classrooms in 20 different primary schools in the Netherlands. And so these are young kids. These are 7 to 10-year-olds basically. And what they did, their 3 interventions, they had first just ventilation advice alone. They just talked to the teacher, not the students. They talked to the teacher about how to ventilate the classroom, and that was it. The second intervention was this same ventilation device, but they also gave the classroom a CO2 sensor with a little red warning light that would flash when it got to, I think their set point was 1,000 ppm. And then the third intervention was ventilation advice with ventilation theme lesson plans. So no CO2 sensor, but they actually designed, I think it was 3 or 4 different lessons about the importance of ventilation and indoor air and reducing humidity and mold and all these different things. And they had the teacher teach it to the students. And so the results were really interesting. They ran this study for about 3 weeks, which was pretty short. But basically, this will not surprise you at all. They found that using the CO2 warning device actually really did help to decrease the CO2 levels in the classroom by about 200 ppm, but it actually wasn't enough to get it below the 1,000 ppm point that they were aiming for. And they found that effect, that reducing effect, was only occurred as long as the monitor was in place. So the warning device, the monitor, was only in the classroom for a week. As soon as they took the monitor out, CO2 levels went back up. So I would argue that they really did not leave that monitor in place long enough. Like I think you need much longer period to entrench a habit, and that could be part of what happened here. But it is, important that if you make people technologically dependent on something rather than teaching them a new behavior, that the behavior will fail when the technology fails, essentially. The second or the third intervention, which was the ventilation theme lesson plan, was very interesting because it helped to enlist the young students in the ventilation action. And they used their remarkable powers of annoying persistence to annoy their teacher into carrying out the ventilation actions. And so actually this intervention actually had a lasting effect. It lasted beyond what had happened with the CO2 warning device. So it carried on. And that's really interesting because it involved engaging younger people. And I thought that was pretty cool. Obviously, just telling people to ventilate was not effective at all. And then some of the issues that the teachers brought up were things like draftiness. People do not like to be cold. Also, in this kind of setting, we've got little children. Teachers don't want to make the kids sick. So it's really hard to convince people to keep their windows open when it's cold outside, for example. So this study was carried out in the wintertime because that's when CO2 levels in the classroom are highest. So there was also an issue with distraction. Some of the teachers they were supposed to be keeping notes in a journal, and they just stopped doing it because they're busy. They've got, I think they had 20 to 25 screaming 7-year-olds in their class, and they were busy. So that's another potential issue. Still, the authors indicated that they found it could be pretty useful until the facilities could be upgraded. So, upgraded. So using these CO2 monitors as a temporary measure. So what role then does CO2 monitoring play during this pandemic or the next one? So I think this is really for you to decide. These are, after seeing some of the issues involved with this, there's utility here, but there's also a lot of issues in creating or transitioning CO2 monitoring into kind of like a public health practice. So it could be useful as an emergency measure, just to create IAQ awareness and to stimulate ventilation behavior, like opening windows and taking breaks to air out the room, stuff like that. So it's also a twofer, and this is something we haven't really talked about here, but having CO2 monitors in place could help improve ventilation and reduce kind of that respiratory disease transmission risk. But if it was rolled out under the auspices of a public health agency with some additional funding and support, it could also be used to collect data on public spaces and figure out where our priority areas are. So this has actually already started. The province of Quebec, they did a CO2 monitoring campaign of, I think, 300 different classrooms sometime in December. And they were trying to get at, which ones of our classrooms are very badly ventilated. So this has utility in that kind of like learning space. The other, if these things are done properly, they could reduce the risk of respiratory diseases generally. But is it a long-term solution? Perhaps not. It might help buy us time to develop kind of a national indoor air strategy that builds on what we've learned during this pandemic and make changes. So I think that something that we're going to have to tackle over the next 6 months to a year is the fact that we've learned stuff now, and we have to decide, what changes need to be made and how. And so CO2 sensing might be kind of a bridging mechanism until we get to that better state. And, if none of these things are considered useful, then perhaps CO2 monitoring might be something to have in your pocket in case you need it as an emergency measure during the next pandemic. So I forget what the cycle is, but it's something like 50 to 60 months between these challenges. So perhaps the next one, this might be something that can be rolled out quickly in the early stages, where we just need to ventilate, where we don't really understand the situation. We just need to make sure that the ventilation aspect of it is taken care of sooner rather than later. All right, so thank you very much. This is my email address. Again, I really actually value your input, your questions, your comments on these documents. We do change and update them over time. So if you have input, please contact me here. And I think we have time for questions. I don't see my clock.
Yep. Thanks so much, Angela. So now we'll go to questions. If you have any questions, please type them into the chat box. We have a few right here. Just before I move on to the questions, I'm putting a link to Angela's document in the chat box. Okay, so first question, I guess it's more of a comment. It would be great to get any recommendations you might have on reliable HVAC evaluation consultants for carrying out evaluations and also for training EHOs for health authorities so that they can carry out better assessments.
Yeah, this is unfortunately a role that NCCEH does not fulfill. We don't endorse products, we don't endorse consultancies or any of those things. But it is very tricky because you really are placing a lot of trust in whoever you hire. I would suggest there are a lot of large consultancies in Canada that could be contacted. I would also suggest reaching out to academic partners. Who knew? I actually knew, but before the pandemic, we didn't think much about our amazing IAQ resources just here at UBC. And, they've provided me with a lot of value in the last so ever many months going through this process. So I would definitely say reach out to your local IAQ specialist in the research world and see what they can, there might be possible to do a joint project together. I know that we involved UBC in the assessment of a hospital in Delta and some other different kind of outbreak situations, which was really useful. So,
okay, thanks. Next question, how much have CO2 sensors been used in studies on aircrafts? I understand that despite air being cleaned with industrial HEPA filters and others during the course of the flight, ppm CO2 increases dramatically during boarding, before takeoff, and during landing and departure. Do you agree with this?
I am not familiar with that particular body of literature. I know it exists. I would say that the HEPA filter, first of all, everything is maintenance, right? If HEPA filters are not being properly maintained on the plane, then yeah, you're going to have situations where ppm is increasing. CO2 levels, though, would not be affected by HEPA filter, right? So you can filter that air all you want, the CO2 is going right through it. So this is why I say that with this issue around CO2 levels versus COVID risk, they are not the same, because some of these measures that reduce COVID risk are not going to affect CO2. But yeah, if that might be an area for me to look into more, is about airplanes. I look mostly about schools, because I'm really interested in this kind of situation where you're asking the occupant to take the action. You're asking the occupant to learn on the job, and you're asking the occupant to, devote some of their time to managing this new technology. Whereas on an airplane, that's something that's more automated.
Okay, thanks. Are there any air filtration monitors that are or could be used with air purifiers that could be used in combination with CO2 sensors to determine a difference between CO2 versus filtered CO2 that may not contain virus?
That sounds like the setup for a really great study. Yeah, I mean, I'm not aware of any research like that. Also, if the question is more about what brand or what model or what type of sensor can do that, that's not our role to make recommendations, unfortunately, about products.
Okay, thanks. Do you have any
for device though? A filter with a CO2 monitor? Patent. Just kidding.
So next question, do you have any recommendations on handheld CO2 monitors potentially being used by PHIs to determine CO2 levels and highlight the potential need to look at ventilation by using CO2 as an indicator?
Yeah, this is something like within your health authority that you can start talking about, is how do we use these CO2 sensors reasonably and intelligently? Because some of those handheld CO2 sensors, they're not actually the type of monitor that you would put on a wall. They're actually safety devices, which means they're meant to monitor at a much higher set point, like around 5,000 ppm for safety reasons, right? Like, I think your occupational exposure limit for CO2 is 5,000 ppm over an 8-hour shift. So those handheld devices are usually meant for that setting, and figuring out, is the worker safe or not? So if you're walking around with that handheld and you're trying to guesstimate whether or not a patio is close to ambient, I'm not actually sure that device is going to do what you want it to do. So this is definitely a conversation that has to happen within a health authority. Like, what kind of sensor are we going to use? Exactly how are we going to use it? How are we going to troubleshoot any kind of issues that come up with communicating with occupants or with the public? Yeah, unfortunately, it's a lot of work to make this into a public health tool.
Okay, thank you. Next question. What's your experience with CO2 monitors and the ABC calibration protocol? Okay, is it sufficient as a replacement for typical calibration against a zero and known span challenge gas?
Yeah, so this is a calibration question. So ABC is automatic baseline calibration. And so this is what's commonly used in demand controlled ventilation CO2 sensors. So basically, you've got your sensor running in the room, it's running all day. Then at night, when nobody's supposed to be in the room and the CO2 level should be close to ambient, the sensor takes a reading at that point in time and says, okay, this is our new set point. This is ambient. And so it's going to say, this level that I'm measuring right now is 450. It may not be. It may be substantially above 450. Say the cleaner just went through the room, or for whatever reason, that calibration may be off, but it's generally okay, as long as, I think the sensor is still supposed to be calibrated with a pure nitrogen gas, I think once a year. So there is like a maintenance schedule to these things. It can't just be, you cannot just rely on the ABC, the automatic baseline calibration, indefinitely. And again, though, a lot of this has to do with how long you would roll these CO2 monitors out for. Are they an emergency measure where you're using them for a few months while we kind of get a bearing on, is this new pathogen airborne? Like, what is the role of ventilation here? Or is it something where you're going to start integrating CO2 sensors into a building IAQ plan over the long term, in which case, yes, calibration needs to be built in.
Okay, thanks for that. Next question, if you scroll down a little bit. Is there a document from the Quebec school CO2 monitoring work? Can you speak to a utility of CO2 monitoring for the purpose of identifying spaces with significant ventilation issues? Any method suggestions?
Yeah, absolutely. This is probably the best use of CO2 monitors in my mind. And so if you go to my my CO2 document, the Quebec document is linked in there. So it's actually in the table. There's a thing that says province of Quebec, and then there's a number beside it. If you click on that, it'll take you to the French document. Unfortunately, it is a government document, so they don't actually provide a lot of detail on exactly where they space out, or how they established everything, and what time frame they took measurements over. It's a little bit detail light, but if you were interested in doing that sort of campaign in your own health authority, say for schools or long-term care homes, then I would definitely suggest hooking up with your local academic assets and see if they can potentially help you. Because as I say, the use of CO2 monitoring for assessing ventilation rates is really, really common in the IAQ world. And it shouldn't be that difficult with a little bit of outside help to set up some sort of monitoring campaign to identify priority spaces. But it really, I think, is a great idea.
Okay, thanks for that. Next question. You mentioned that this tool might be a temporary solution, but not recommended for long-term. As a short-term temporary measure, do you expect there will be any guidance provided on how to best implement in the short term?
I have been waiting and wishing and hoping for CO2 guidance for the last 6 months. It hasn't come out. I think it's because, of all the issues that we identified here, it's really hard to operationalize. And so, perhaps as a result of this pandemic, we're going to see somebody actually try to seriously tackle this and say, we're going to turn this into a public health tool, and here's how. But I can't say who's going to take that on. I wish somebody would.
Okay, thank you. That's the last of the questions we've received so far. And yes, this presentation will be shared on the NCCEH website and will be sent to all registrants of this webinar. And any other questions from the audience? If you have further questions later on, feel free to email Angela directly with them. And with that, we'll wrap up our webinar. And thank you all for attending, and in particular to Angela for presenting today.
No problem. Thank you very much.